I'm Karen Stockton. I'm from Modoc County. For those of you that don't know where that is, it's the extreme northeast corner. A population about 9,500. I have 10 direct service staff, including the telepsych docs. So a lot of the things that you all do that I'm so envious of don't work for us. I mean, we just don't have the capacity. And so as my, for a year, deputy director, before that I was the director of health services, but also the acting director of mental health, we had some real challenges in figuring out what to do. But when we talked about this in our MHSA integration plan, we were already planning to integrate behavioral health. And we wanted it to be other than just, you know, seeing each other in the halls and collaborating, but we really wanted to do something serious about true behavioral health integration. And since we were already working on that, when we became a part of the collaborative, we tried to integrate our primary health care into that and making a plan. So what I'm going to share with you today are just a couple of the initiatives we did in the SCCI Learning Collaborative. And I would like to say, it's especially true for us as small counties, but I think it's true for larger counties too. Getting involved in a learning collaborative like this is really fertile ground for learning and for thinking about things in different ways than you do when you're so close to it. When you just see what you do and what you encounter, you don't learn as much as when you're sharing and you're sharing a learning process or journey with other counties that may have very different problems, but sometimes the approaches can be the same, and you can certainly learn, and it stimulates the thought about that. So what I find is that being a part of this process for a couple of years has really changed the things that we talk about and the things that we look at. So being different is good, I think, because it challenges you to think about what you're doing in different ways. And I hear us say, well, we do good work, but learning to document that and find ways to do it, it really helps in this process. So that plug for that. So we were really looking at how can we achieve better health status. We had the unfortunate experience of losing a couple of people that we worked with far too young. And so we took seriously the 25 or worse loss of years of life. And we wanted to take that personally. We knew if integration was going to happen, we had to take it personally. It had to be a matter that was right up front for us. And being a family member, that becomes even more important to me, that we take seriously what happens. So we decided a couple of the goals that I want to talk to you about today. There were many others, but we wanted to incorporate physical health monitoring into our behavioral health services. We have no FQHCs in the county. We have a couple of critical access hospital-based clinics and a couple of other clinics that are kind of isolated and 20 or 30 miles away at least. And so we knew that we had to assume more responsibility. My placing staff there, I mean, I have 2 MSWs and an LCSW and 2 LVNs. You know, putting people out there wasn't going to work. So we decided that we were going to at least start with our own staff and start monitoring physical health indicators and take responsibility for closing the communication loop around that. And we knew we had to have a way that was to track it, that we could run, that we don't have an IT staff, so it had to be something that we could do that was fairly simple, and that we could collect the data. And so that's why we decided we were going to use a registry. In our experience with both the former and the current electronic health records, we couldn't do what we needed to do at the client level and even at the agency level to the degree that we knew we needed to be able to do it to track outcomes. So I wanted to talk about the PDSAs we did around the integrated intake process. My little staff managed to do 20 PDSAs just on this one area. You know, so it was interesting to see him gear up and to take it personally, and it wasn't, you know, it wasn't, this isn't my job, but it's how do we do this and how do we support each other to actually manage to do this. So they tested lots of forms, how they wanted to collect information. They would have what I don't call failures, but missteps, and they would learn and say, nah, that didn't work. We should have talked to, you know, the front office staff before we asked them to do this, and those kinds of things. But they learned a lot around doing that. And so we wanted to also look at how do we integrate the behavioral health clinical processes. And I mean, we've all talked about 42 CFR, so I'll go on. I mean, what we decided is we were going to go to the level of 42 CFR. We weren't going to let us get in get in our way initially, and then we were going to advocate like everything to get SAMHSA to perhaps change or redefine or explain what the barriers were around that, if that's what we were going to accomplish. And so we wanted to also then provide an integrated assessment for children and adolescents. It's one, and we separated the substance use and mental health assessments for adults. And then those assessments all feed into a whole health. So I kind of tracked it out. We established a separate role for an intake clerk, trained them. We found that a lot of the data we were getting is complete, and we said, well, if we provide more support to the individuals as they come through the door, perhaps we can get it more complete. And particularly around consents for primary care, we found that a lot of times that would just get skipped over. And we needed to frame in the context of why we were asking for these consents and why we were doing an integrated intake. And so once they've experienced that, then they go to the nurse for a thorough medical history, vitals, PC status, and then they go on to the assessments. And so I showed here, then all three of the domains feed into one integrated plan in one team in planning it. Some of the challenges we encountered were getting buy-in from staff and consumers. And one of the things that we found helped us with that is having an integration committee that was composed of consumers and staff and other stakeholders. They met regularly, talked about cultural competency, about what was working, what wasn't, what was important to include. And we also provided some whole health wellness training and talk about how that's a best practice, and celebrated success stories as we went along. And another challenge that we've had is scheduling and coordinating timely intake and assessment appointments. It does take more time. And so we actually hired some additional staff time to complete the assessment so we could get everybody on board. And we also trained the intake clerks in interview skills, had them practice it, and vary the wording so that they felt comfortable in explaining this. At this point in our testing, we're also considering perhaps a preliminary triage process so that if we don't need a full assessment, then we can shorten the system for them and the time to treatment. One of the things I might say is kind of a fear of mine is that when we initially started talking about doing a holistic assessment, the reason we did it is I would get the data, and mental health and SU staff did good assessments in their domains, but they really underestimated consistently the SU assessment. And so I'm a little fearful of triaging it and then going back to where we are. I want to skip a little bit, or just talk a little bit about the outcomes. Clients have been very receptive to us doing physical health screening. Some people thought that they wouldn't, but the feedback has been very positive. And we identified as a client story one person with a very high blood pressure, immediately got them into care, immediately got it under control. Could have been a really bad outcome if we hadn't done that. And I think that probably, if I want to say anything to you that we've learned and changed how we're thinking, is the discussion about who owns data. You know, for all of the registry collection and stuff, I think as administrators and even clinicians, it's really easy to think that we own the data, or that we own, or that the state owns the data to demonstrate outcomes. And I'd like to submit to you the part of the discussion we had about that, of whether the information we collect in the registries or wherever, however we collect it, is the client ownership of that mandatory or optional? In primary care, I think we would say it's mandatory. That's our data, it's about us. And I would submit to you it's the same in behavioral health. Clients should see the results of their data, they should have it, and it's really theirs. And they are kind enough to be willing to partner with us to show what we do. But we get that to show us their data and allow us to use that to get funding to help them. But I think we need to stay on the focus of whose that is and what we're about, because it's really easy in all of this complexity to lose track that this is about the clients. It's their data. They allow us to use it, but it isn't ours. And so, you know, I think that's why one of the reasons I've been so sold on the registry, and I won't have time to go into all the details of that, but registries allow us to make available on a regular basis to clients their own data. And I'd like to close and cut it very, very short, and you have the other things in my handout. But one of the things that really impressed us in that is that we were, in trying to connect with primary care, the nurses were working with the clients and say, you know, I really ought to make an appointment for you to see your primary care physician, your blood pressure's high or whatever. She said, I got all kinds of reasons from all kinds of clients about why they didn't want to do that. And there was quite a bit of resistance to it. She said, as I showed them their registry data over time and would reintroduce the conversation, when they would see that they weren't getting better, then they would say, yes, I think it's time. I need to see my primary care physician. And so in this one LVN, using the data consistently in a period of less than 2 weeks, connected 6 formerly resistant clients to their primary care physician. We couldn't have done this without the registry, without our commitment to combining primary care. And so I think I'll leave it at that. Thank you for your time.
I think that was really a wonderful kind of way to pull this all together, because Karen, if I'm not misinterpreting what you're saying, you're really saying that, you know, total health is obviously it's the person who's needing and receiving cares, body and heart and soul, but it's also all of us have to take responsibility across the systems that we have created over hundreds of years now. So I really appreciated what Lily talked about. I think it was what's the blood pressure cuff for substance use disorders? I mean, we really have to think in those kinds of ways. And so I know we've lost some folks, because there are folks going home to partners for Valentine's Day from this meeting. But just if there's any quick comment or question, I can try to repeat it, or, you know, anybody have anything you want to share? Great. I just really want to close by thanking you know, all of the systems that did these presentations. In the Care Integration Collaborative that I had the privilege of leading and learning from, quite frankly. We asked our teams in the last session to give us 15-minute briefings. And that was collapsing, learning across mental health, substance use, primary care, and health plans. And they struggled mightily with both, communicating the excitement, the scope of their work, and really telling the story. It's a very challenging thing that we asked all of our presenters to do today. We hope it just whets your appetite, because there is so much rich learning and sharing. And I think our challenge in this state is really to figure out how to mine that wealth of evolving knowledge, because ain't nobody got the answer. I mean, you've heard a lot of different strategies. So with that, we really want to thank you. I want to thank my partner in crime here, Jen. We want to thank you for just sharing the journey with us today. And please be sure, I have to go all the way back, oh my God, through 25 present. Just be sure, most of you know how to reach one of the two of us, but if there are questions for our presenters and you don't know how to reach them, just shoot us the question and we will forward it on. And also, we will be posting all of this information on the website for CIMH, I think by tomorrow. And you'll be able to look at information that you can't see in tiny slides. So thank you all for sticking it out, and I think we're going to reconvene. I don't know if they're done in there, but we'll reconvene in just a couple of minutes. So thank you.